one very interesting area that continues to evolve is the idea of dropping aspirin after some period of time post ACS or post PCI and continuing with P2Y12 inhibitor monotherapy. So there's now a class 1 recommendation, which I think has been overall well received by a lot of people who have been, wanting to shorten the duration of DAPT. But traditionally, people have been dropping the P2Y12 inhibitor.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to Parallax. Welcome to another episode. It's another Monday. Thanks for tuning in every other Monday to listen to one of our exemplary guests. My guest on today's show is Dr. Michelle O'Donoghue. Dr. O'Donoghue is a cardiologist at Brigham and Women's Hospital, and she is a senior investigator with the TIMI. So with that introduction and without much further ado, Dr. O'Donoghue, thank you so much for doing this for us. Welcome to Parallax. For the audience, if you haven't seen the guidelines already, then the American Heart Association and the American College of Cardiology recently published the updated guidelines on acute coronary syndrome, and Dr. O'Donoghue is one of the co-authors on that guideline document. So once again, Dr. O'Donoghue, welcome to Parallax.
Thank you so much for inviting me. Delighted to join you.
Well, thanks. So like we were discussing, I think it's timely and important that we discuss the guidelines. And I think just for the listenership, I think, many of us who reference these guidelines when we are taking care of patients, at the trenches, are often curious to learn how the process of putting together a guideline writing committee works and what all goes into then writing these guidelines. So I think if you can shed maybe a little bit of light into this process before we delve into the guidelines themselves, I think it'll be insightful for the audience.
Sure. No, it was a very interesting process. I think we really had our work cut out for us in a lot of ways because the US guidelines in the ACS space had not been updated in more than 10 years. So there were a lot of studies to review, a lot of data to obviously walk through together as a group. And then part of what we were tasked with doing was combining for the first time in the United States the non-ST elevation ACS with the ST elevation MI recommendation. So putting that all into a single document and at the same time try to keep it all to less than 100 pages because we know that it's better to keep these documents focused. I think there was a lot to get through, but importantly, I think one of the nice things that we did when we assembled the writing committee was really try to get many different viewpoints. So we had representatives from the emergency department, paramedics, EMS care, also a patient representative, nurse, pharmacist. So, really different perspectives. And I think it allowed us to really create a comprehensive document that covered ACS care from many different angles.
Yes, I think it's, I know that it's a very involved process. How long did it take for the group to actually come out with a final draft before it was published?
Around about a year, I think was about what it took. And so it came in on time. It was a lot of work towards the end. But these were, weekly meetings that we had between the writing committee members and the leadership committee as well. It was a heavy task list for the writing committee members where we were trying to produce new sections on a weekly basis and review and turn those around. It takes a lot of work, and in the end, it's very gratifying. I think we're quite pleased with what we were able to put together.
Absolutely. I think these, like I said, these guidelines are referenced by clinicians who are taking care of patients at the trenches. And, I think the impact that documents like these have on patient care, is immeasurable. So let me start by asking you, the and this audience certainly does not need to be primed to what an acute coronary syndrome is. I think, but just to sort of make sure that we're on the same page, the spectrum of acute coronary syndromes includes unstable angina, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. So, I think the first step in writing the guidelines is sort of establishing the accurate diagnoses. So we know that for a learned cardiology audience, symptoms and electrocardiogram and biomarkers. Would you have anything else to add here?
I think it's an important point because we wanted to make sure that these guidelines were focused really on the type 1 myocardial infarction subtype. So those in whom there's presumed plaque rupture. Because, of course, I think there's been greater appreciation of the different subtypes of myocardial infarction, including myocardial injury, and then other types of related disease states that we're also beginning to better understand, such as MINOCA and management of those other conditions. So I think important just to put forward first that this document was purely focused on those with type 1 MI. And it also was coming from the perspective of starting when the diagnosis was already made. Because in the US, we had recently had the chest pain guidelines released. And I think that was a very comprehensive document in terms of thinking about the evaluation of patients with chest pain in the ED. So our recommendations largely mirrored what was already stated in that document with the use of clinical decision pathways, as well as, of course, troponin, in particular, high sensitivity troponin, for helping to make that initial diagnosis.
Absolutely. I think you raise an important point there of differentiating troponin elevation or troponemia, as I've called it, yeah, attributed to plaque rupture or plaque erosion or calcified nodule. Those are the pathophysiologic types of type 1 non-ST segment elevation myocardial infarction. Because that has implications for how we triage these patients, whether we want to deploy a selective invasive strategy or an early invasive strategy in these patients. Certainly that does not hold if a patient is presenting with quote unquote STEMI, which is ST segment elevation myocardial infarction. I think it's important here for me to ask you, because I certainly have seen this many times, in clinical practice, particularly when it comes to triaging these patients in the emergency rooms and emergency departments, is what I've started to call undifferentiated troponemia. And by that phrase or by that statement, what I mean is that we're not entirely sure what's leading to this high troponin in this patient, because clearly a subset of these patients are, which is not infrequent. I'm sure, those who are listening who run the consultation service for cardiology at their hospitals will agree that many a times we get consulted for high troponin, and we have to make a determination as to whether this is type 1 or or some other subtype of non-ST segment elevation MI. So my question to you here is: do the guidelines address this ambiguity when it comes to quote unquote undifferentiated troponemia? Or this could also fall under the rubric of, if these patients do end up getting invasive angiography and have normal coronaries, like you mentioned, MINOCA, which is myocardial infarction with normal coronaries, do the guidelines discern these vexing topics, particularly when it comes to troponin, for making a diagnosis of ACS?
You make an excellent point, because as straightforward as it may sometimes seem on paper, I think the reality is we all know that there are those instances where we are unsure if this is a type 1 MI event. If the patient comes in, her troponin is elevated, And they have symptomatology that's either mixed, or it's unclear whether or not this could be a primary ACS event. So the ACS guidelines didn't dive into that topic in too much depth intentionally, because the universal definition of MI document is quite useful in that regard, as well as the chest pain guidelines that had been previously released, and I think sort of walk through that decision making in detail. But I think where the ACS guidelines are perhaps helpful in that regard is thinking about other types of risk stratifiers that may help people with some of those decisions surrounding whether or not to send somebody to the cath lab. So thinking about a routine invasive strategy or a more selective invasive strategy for a patient with non-ST elevation ACS. So using some of those additional clinical predictors, things like whether or not you're sort of seeing a clear rise and fall in troponin, of course, can be helpful. But also the association of, EKG changes and other types of supportive findings that may suggest that there is acute ischemia at play. So I think one of the additions for this ACS document was that lower risk patients with ACS for non-ST elevation ACS, that a selective invasive approach can be employed. And I think importantly, that does not mean just sending the patient home, but rather thinking about further risk stratification with additional imaging. So, for instance, with the stress test to help determine who may in fact benefit more from a trip to cath lab.
Yes, so I think it's also a good strategy to risk stratify these patients with non-ST elevation myocardial infarction based on established risk scores that we are aware of. Certainly your group has published a score which I tend to use in clinical practice, which is a TIMI risk score. And then you've got GRACE. I find TIMI to be more easy to use because it's sort of you can use it at the bedside. I dichotomize based on symptoms and history and patient characteristics, and it's easy to reproduce at the bedside without having to pull out a computer on Google or any other search engine that we use. With the advent of AI, I'm sure that's easier now. And then, the one other thing in these patients I tend to get early on, if there is troponin and there are maybe non-specific EKG changes which is a very common clinical scenario. I mean, a lot of these patients have undulating ST segments, which are, it's just non-specific STT changes with troponin elevation without a clear rise and fall pattern. And symptoms are ambiguous. You're not entirely sure if this is an acute coronary syndrome or not. I find getting a resting echocardiogram is very helpful to see if you can discern a resting wall motion abnormality, or if there has been an interval decline in left ventricular systolic function in comparison with the most recent echocardiogram on record. For you to then determine if this patient can then have a selective invasive approach or an early invasive approach. Do you think that's a reasonable strategy?
Yeah, you're right that I think that echo can be a useful tool for helping to detect ischemia. We know that wall motion abnormalities are one of the earliest signs of myocardial ischemia. So I think it can be a useful tool. The reason that it's not really addressed in depth in the ACS guidelines, though, is because it is starting from a standpoint of there being a confirmed diagnosis or a suspected diagnosis of ACS. And so the use of echo is mentioned in the ACS guidelines, but more in the context of patients with cardiogenic shock or those with possible mechanical complications where urgent echo is really indicated.
So once you've established the diagnosis of type 1, myocardial infarction, certainly in the throes of a STEMI, these patients go emergently to the cath lab, for primary percutaneous coronary intervention, or revascularization. In non-ST elevation MI, or even in STEMI, I mean, I think that's why it's sort of. I think it was a little novel that the college and the American Heart Association came out with a unifying document for ACS. Let's talk about adjunctive medical therapy upstream or en route to the cath lab. Do the guidelines differentiate or simplify what this looks like in comparison with the earlier documents?
I think one area that remains still controversial is the question of pretreatment with antiplatelet therapy. The European guidelines had advised against pretreatment with P2Y12 inhibitor. Of course, aspirin is still universally endorsed across the documents for initial treatment of a patient with suspected ACS. But the timing of the P2Y12 inhibitor, remains debated. In the U.S. guidelines, if you know that there's going to be a delay of more than 24 hours before the patient goes to the cath lab, there is basically the option to administer either ticagrelor or clopidogrel. But we recognize that the evidence is not quite as firm in regards to earlier initiation of a P2Y12 inhibitor. So we still wish that more studies would be done in that regard. But another area that's a new recommendation for the ACS guidelines is for use of bivalirudin as an alternative to unfractionated heparin for patients with ST elevation MI, based on a growing number of studies that have suggested that there does appear to be a benefit for using bivalirudin for reducing bleeding as well as mortality in STEMI patients.
So, upstream therapy, I'll share with you my clinical practice, and then you can add to what is contemporary in 2025. I tend to not upload. When I say upload, I administer a loading dose of a P2Y12 in the emergency room. Like you mentioned, several contemporary trials have demonstrated lack of benefit to that approach. Certainly, these patients get heparin, intravenous and fractionated heparin, bolus dosing, they get aspirin, and then they get sent to the lab. Now this is also true for non-ST segment elevation MI, but certainly even for STEMIs. And then, the first step is to then discern the anatomy to see if it's amenable for percutaneous revascularization, or whether we should stop, if there's multi-vessel disease, stop, and get our surgical colleagues on board to determine suitability for surgical revascularization. Obviously, if it's a STEMI, you want to address the culprit vessel, and then we can talk about staged revascularization as we discuss this. I tend to usually go radial approach for my access, then administer P2Y12 in the cath lab. If the patient is not comatose or not intubated, or is otherwise stable and can take a pill for me whilst recumbent in the cath lab, then we usually go with ticagrelor or start cangrelor in the cath lab, and then do the case on heparin, not administering bivalirudin. Do you approve of this strategy?
No, I think that there is still variability in practice, and the guidelines do allow for that. I have to say that personally, the times that I preload with a P2Y12 inhibitor is if I know the patient is going to be getting PCI, and if for whatever reason, they're not a candidate for a more potent P2Y12 inhibitor for like ticagrelor or prasugrel, then I do preload with clopidogrel in those instances, because I appreciate that clopidogrel is a prodrug, and it requires several hours for it to really achieve steady state. So I think that conceptually it makes sense to preload with clopidogrel. As you point out, I think the only negative really that we're aware of at this stage is that if a patient needs to have bypass surgery, you may then have to wait a little bit more time for either clopidogrel to wear off or accept the increase in bleeding risk. But like you said, I think radial approach is an important thing to consider as well. That is also recommended in the guidelines to help reduce bleeding, vascular complications, and also mortality. And also now there's a recommendation for intracoronary imaging to help guide PCI and ACS patients with complex coronary lesions as well.
Yes, the use of intracoronary imaging in the U.S. has been, unfortunately, has even the contemporary reports that I've read is less than 50%. I mean, I think it's the zone is anywhere between 40 to 50%, so it's less than 50%. And I think the guidelines specifically coming out with that recommendation, if not across the spectrum of all PCI, certainly in PCI in the setting of an acute coronary syndrome with complex lesions, I think is an important adjunct or an important addition to the document. There's lots to talk here. So I think choice of P2Y12, I came across a perspective where the ESC guidelines were compared with the American guidelines for acute coronary syndrome. And whilst our European colleagues give us a choice of prasugrel and ticagrelor, you certainly mentioned clopidogrel. And I can share my practices in older patients. I tend to go with clopidogrel in comparison with younger patients, where I tend to go with a more potent P2Y12. But just to complete what I was saying, the US guidelines prefer ticagrelor over the other two. I run into this not infrequently where patients just can't afford ticagrelor. So upfront, even though they get a loading dose of ticagrelor, and they are getting ticagrelor whilst they're in the hospital, when the time comes to discharge, I find myself not infrequently reloading them with a loading dose of clopidogrel, and then discharging them on a stable dose of clopidogrel, 75 milligrams daily. And I tend to, in patients where I think there may be hyporesponsiveness to clopidogrel because of CYP2C19 metabolism, I try to get genetic testing for platelet reactivity. No, not genetic testing, just testing for platelet reactivity. And I do think that approach probably needs to be customized to the patient in front of you. What comments do you have for these decisions and these approaches?
You touched upon many important questions, and I think that to summarize, one question is, what is the choice of the P2Y12 inhibitor? And then the second, it sort of dovetails into duration of DAPT, which of course is always quite controversial. When it comes to the choice of P2Y12 inhibitor, the US guidelines now preferentially recommend both ticagrelor and prasugrel for patients undergoing PCI over clopidogrel. But clopidogrel certainly can be used for those patients in whom you're either unable to afford it. There are some people who are obviously not going to have access to some of these other more potent therapies, or there may be contraindications. So prasugrel or ticagrelor for PCI patients with ACS. We don't recommend one over the other for PCI patient, and that's one area where perhaps we differ from the European guidelines, where based on the results of ISAR React 5, they took a step forward to endorse prasugrel preferentially over ticagrelor. The US guidelines really provided still equal footing, but did certainly recognize the findings in ISAR React 5, but ultimately the writing committee felt that additional data would be useful to basically confirm what was seen in that study. For those patients who don't undergo PCI, that's where ticagrelor, for instance, for a medically managed patient, is recommended over clopidogrel. For a patient who's not getting a stent, there we don't really have any data to support use of prasugrel. So that's why that was not part of that particular recommendation. But I think, one very interesting area that continues to evolve is the idea of dropping aspirin after some period of time post-ACS or post-PCI and continuing with P2Y12 inhibitor monotherapy. So there's now a class 1 recommendation, which I think has been overall well received by a lot of people who have been, wanting to shorten the duration of DAPT. But traditionally, people have been dropping the P2Y12 inhibitor. Right now, though, based on the evidence that's been accumulating, it really seems that the safer strategy between those two would be to discontinue the aspirin. So for patients who have tolerated the combination of aspirin and ticagrelor, there's now a class 1 recommendation that you can stop the aspirin after 1 to 3 months and think about continuing ticagrelor on its own. We're not yet confident about the safety of clopidogrel monotherapy. There's at least one study suggesting that post ACS that may not be sufficient. And so I think that this will be an area, though, of continued study where we may have more opportunities for monotherapy strategies down the road.
Yes, it's interesting you mentioned P2Y12 monotherapy. Certainly in patients with stable ischemic heart disease who require percutaneous revascularization, after an abbreviated DAPT, which is dual antiplatelet therapy duration, my practice has transitioned to offering them P2Y12 monotherapy with clopidogrel, and I recently came across another publication where I think that strategy was also tested with ticagrelor. I'm a little reluctant, like you mentioned, to sort of taking that approach in a post ACS setting, certainly within the first year. And I always ask myself this question, as to whether, like, at what point in time do these patients then transition from, post-acute coronary syndrome patient to a patient with chronic coronary syndrome or stable ischemic heart disease? Um, but I like for them to remain on extended dual antiplatelet therapy, particularly if, there's complex, there's in terms of like, if there's complex coronary disease with multiple stents, or certainly with, distal left main lesions, or with complex heavily calcified lesions, requiring, plaque modification with either lithotripsy or debulking with, atherectomy. I tend to keep these patients on dual antiplatelet therapy for longer. And then, like you mentioned, I'm not as comfortable in discontinuing aspirin in these patients, certainly within the 1 year. But beyond the 1 year, I ask myself whether it's safe for them to stop the aspirin and continue the P2Y12. What were your thoughts be on this approach for these patients?
No, I think you're right. I think people are starting to think about this differently. And in part because we have newer studies, for instance, like Host Exam, that have compared clopidogrel monotherapy to aspirin monotherapy. That had been previously done, a long time ago with trials like Capri. But they're all telling us a little bit the same thing. One is that clopidogrel appears to be more efficacious than aspirin when just considered as a monotherapy strategy. And it doesn't increase the risk of bleeding compared to aspirin. I think there's always this misconception that clopidogrel must cause more bleeding than aspirin, but it doesn't. If anything, there's actually less bleeding with clopidogrel. So I think that, things are starting to shift. People are thinking about stopping the aspirin. The part where we're still just nervous is that we know that about a third of people don't respond to clopidogrel the way they should. And, in part that has to do with a genetic variant that interferes with the ability to metabolize clopidogrel properly to its active form. But, so that gives you pause. I think more than a year post ACS, that they're now a lower risk patient. And so you may feel like dropping the patient down to clopidogrel from a more potent P2Y12 inhibitor is appropriate. And you may even consider a monotherapy strategy. But we don't know whether or not platelet function testing or genotyping should maybe be incorporated to some of that decision making if you are going to use clopidogrel as a monotherapy strategy.
Yeah, so I think it'll be helpful for our listenership to learn from you about, clinical scenarios when you tend to order platelet reactivity unit testing clinically to make decisions. I certainly tend to do it, if there is hyperacute or subacute stent thrombosis on a particular P2Y12, and then, I've encountered that less so with, less so with ticagrelor because it's an active metabolite. It's not a prodrug like prasugrel and clopidogrel are. With you mentioned clopidogrel is a prodrug, requires a 2-step conversion. Prasugrel requires just a 1-step conversion. So I tend to do that in patients in whom I'm switching for whatever reason from ticagrelor to clopidogrel, or in patients who've had stent thromboses, whilst being on either clopidogrel or prasugrel. And then I think another topic which I've encountered clinically, which I still struggle with, and I think it'll be great to garner your insight, would be the topic of aspirin allergy. So if you can, just shed light on those two questions, I think that'll be very illuminating for our audience.
Yeah, no, thanks. One area of continued interest for me is that question of genotype or platelet function testing being incorporated into clinical decision making for choice of P2Y12 inhibitor. There have been many studies that have tried to tackle this, and by and large, they have suggested that it can be a useful tool for helping to perhaps either escalate or de-escalate potency of a P2Y12 inhibitor. It's tricky because you can look at some of the trials that have just shown, like Plato, that ticagrelor is superior to clopidogrel, and that the curves continue to diverge over time. So suggesting that there is continued clinical benefit that can accrue. But others argue, well, what if we just treat with ticagrelor during that early high risk period, and then you could use a tool like platelet function testing or genotyping up front to help decide whether you could then drop that patient down, de-escalate the potency to a drug like clopidogrel. It's tricky because many of the individual studies were underpowered, and much like you alluded to as well. When does an ACS patient really become a more stable chronic coronary disease patient? So really, when should you be pulling the trigger if you are going to think about a strategy of de-escalation? So that's where there's uncertainty still at this point. And right now the ACS guidelines offered a class 2B recommendation. When it came to the topic of aspirin hypersensitivity, a strategy of aspirin desensitization is recommended in the ACS guidelines. And I think that is a strategy that now is certainly adopted more and more. It used to be that people would just turn to clopidogrel, for instance, as a monotherapy strategy. And I think as there's more and more confidence now with, for instance, ticagrelor monotherapy, it is a consideration, but really we don't have any data for a monotherapy strategy early post ACS, which is why aspirin desensitization is still recommended as an initial approach.
Well, excellent. So moving on, so once these patients have been revascularized, they've been to the cath lab, they're now on dual antiplatelet therapy. I think my practice, used to be a cornerstone of therapy in patients with ACS. Now, if their pumping function or their ejection fraction is normal, and if they don't have any other comorbidity which requires them to be on a beta blocker, for example, primary or benign essential hypertension, I tend not to prescribe them a beta blocker. And this is following the trial which was published in, I believe it was last year or maybe 2 years ago. What are your thoughts there? What is your strategy there, when it comes to ACS in particular and beta blocker therapy?
Yeah, you're touching upon all the hot topics. Now, the beta blocker one is tricky. We do have evidence, albeit older clinical trials, that have suggested benefit from beta blockers, especially early during the course of an MI. So when you look at trials like reduce AMI that you alluded to, suggesting no clear benefit from a beta blocker, that's not really looking at the very early stage ACS patient, where they still may be at high risk of arrhythmic events, for instance, during that early STEMI or even higher risk non-ST elevation ACS patient. Um, those are also patients who were all revascularized, which is not always going to be the case. On the flip side, that there are other trials like ABYSS that were presented that suggested that then discontinuation of aspirin aspirin, sorry, have me back on aspirin, discontinuation of beta blocker further out post an event may come with some risk associated with it. So it's tricky because once you have the beta blocker on board, is there then any potential harm from discontinuing it? That's really an area that we need to better understand. And I think that there are going to be ongoing studies looking in this particular space, but the guidelines still endorse use of beta blockers for patients without contraindication early in their ACS course.
Excellent. And, continuing on controversial topics, I think I should probably have you also comment on using colchicine post MI or post ACS. What are your thoughts there? I know there, when I read about a meta-analysis, I found out that even though there may be a benefit toward cardiovascular mortality, there was a poor signal when it came to all-cause mortality. And I think I still, and then still, we see trials being published where they show benefit with colchicine. What are your thoughts there? Or, what approach did the guidelines take on recommending or not recommending colchicine acutely in patients post ACS?
Yeah, it's been a confusing space. And as you say, it's another area of controversy. We have more data supporting use of colchicine in patients with more chronic coronary disease, but also some evidence that suggested clear benefit post ACS. Now, I should note, though, that when we had drafted the ACS guidelines, our 2B recommendation, just a somewhat weaker recommendation for considering that one may consider use of colchicine as an additional add-on therapy. That recommendation was voted upon before the presentation and publication of the clear synergy results that more recently suggested no benefit for colchicine post ACS. So, would the results of clear synergy have changed our recommendations? Impossible to know. But it's possible that that will be re-examined as there are further guideline updates in the future. But that was not something that had come into our decision making. So the recommendation for 2B was based on the available studies that had suggested benefit without any a clear trend towards harm, albeit even that part has been controversial.
Excellent. So we've talked about dual antiplatelet therapy. We've talked about beta blockers. We've talked about colchicine. Certainly if patients have ischemic left ventricular systolic dysfunction post ACS, I tend to prescribe them with a mineralocorticoid receptor antagonist. I tend to prescribe them with an ACE inhibitor. Do you have any preference of an ACE versus an ARB or an ARB ACE versus sacubitril valsartan? What is your approach there?
Yes, no, there was also a lot of discussion about, of course, the increasing use of ARNIs appropriately for patients who have heart failure. The way the recommendations ultimately landed was that ACE or ARBs are recommended for patients, for instance, with reduced ejection fraction, but that initiation of an ARNI has not been shown to have clear benefit in the setting of an ACS. Now, of course, we have separate trials that have supported the use of ARNIs, and the feeling is that there's no clear harm from initiating the ARNI in an appropriate patient post ACS. So, if you're planning to use an ARNI down the road, the guidelines don't tell you that you can't do that. But rather, there's no clear indication that there is preferential benefit for initiating an ARNI in the setting of an ACS over an ACE or an ARB alone. So that's why it's a little bit nuanced in that regard. But ACE or ARB is recommended in higher risk patients as a class 1 recommendation, and can be considered in really all patients with higher risk coronary disease as well.
So I'm gonna ask you another question, which I think is controversial, in the clinical spectrum, and that is in patients who have post-acute coronary syndrome, ischemic left ventricular systolic dysfunction. Maybe they had ventricular tachyarrhythmia, maybe they did not have ventricular tachyarrhythmia. What stance do the guidelines take in? I think, what is your clinical practice when it comes to discharging these patients on variable external defibrillators? Because we know that implantable cardiac defibrillators certainly are contraindicated in 40 days post-MI. What is your practice there, and what stance do the guidelines take?
Yes, they allow a little bit more flexibility actually for implantation of an internal cardiac defibrillator in very high risk patients who are demonstrating clear ongoing ventricular arrhythmias early, not early post ACS. What I mean is very early post ACS, but rather within that 40-day window. So there is now some flexibility in that regard. I mean, just like you said, I mean, we have had clinical trials that have suggested potential harm from routine implantation of an internal cardiac defibrillator early post MI or also post CABG. And that's where that original 40-day recommendation had come from. But it's tricky because what do you do with a patient who does have ongoing ventricular arrhythmias early post ACS that sort of persist beyond the first few days? And the wearable devices, such as the life vest, the trial did suggest that for people who wore the defibrillator, that those patients did benefit from it. So even though the overall trial results were neutral, in part that was related to compliance with wearing the vest. And so, I still think it's about appropriate patient selection. And so the guidelines do allow some degree of shared decision making between the physician and the patient in terms of what the right step might be.
All right, so we move along. So now we have our patient on a beta blocker. Maybe we have our patient on a spironolactone, or a neurohormonal blocker. And we check hemoglobin A1C to make sure the patient's not a diabetic. I also check a thyroxine stimulating hormone level to make sure they don't have subclinical hypothyroidism, because that's been associated with adverse outcomes in patients with acute coronary syndrome. And then you certainly, there is a school of thought that you should not check lipids acutely. I tend to still check them whilst they're in the hospital just to get a baseline. And then we have to start them on lipid lowering. The medication of choice is a statin, not only for lipid lowering, but also its pleiotropic effects, on plaque stabilization. And then we have non-statin therapies, which are adjunct to lipid lowering. So, and I know that you have, expertise in that particular realm. So I think, insights from you, specifically when it comes to lipid lowering and, investigating underlying lipid profile in these patients. A lot of them have mixed atherogenic dyslipidemia. What is your approach in managing, some of these chronic disease states in these patients?
Yeah, no, I think that the U.S. guidelines have been a little slow, honestly, to be as aggressive as I think we should be about LDL lowering early post ACS. So I think one important message from this ACS guideline update is that lower is better. Traditionally we've had the target of less than 70 milligrams per deciliter for LDL cholesterol, or 1.8 millimolar. But we now have a new recommendation for targeting really down below 55. So for patients who come in who are already on perhaps a high intensity statin and their LDL cholesterol is between 55 to 70 milligrams per deciliter, that you can further um, uh, add on a new lipid lowering therapy to get them down to an even lower LDL goal. So that's an important step forward, I think. So, as you said, high intensity statin therapy recommended for all, with the option to add concurrent ezetimibe. And then for patients who are not at LDL goal, really you should be checking that LDL as soon as they come in, depending on where they're at and whether or not they're already on the statin and ezetimibe. You can further add on an additional agent such as a PCSK9 inhibitor or bempedoic acid to try to get them down to a lower LDL goal. And then post discharge, importantly, rechecking their LDL cholesterol again in about 4 weeks or so in order to determine if you need to add on yet another therapy or further intensify what they're on right now.
Yes, which then brings us to what I think is going to be the next big chapter in within lipid lowering for our patients is chronic disease management. So now this patient is out of the throes of an acute coronary event and has been following up with you in clinic for several months. At what point in time would you recommend? So maybe they are on appropriate lipid lowering, um, and their LDL is within or if not within the recommended range, is still approaching the recommended range, and they don't have high triglycerides. So if they do, I tend to add icosapent ethyl, before I add, adjunctive therapies like ezetimibe or bempedoic acid. Bempedoic acid I try to reserve for patients who are not tolerant to statin therapy. And, I think the same goes true for PCSK9s. My question to you here is at what point do you offer them Lp(a) testing, or is that something that you reserve for patients who have not had a coronary event and who, are looking for primary prevention, or, come to see you for primary prevention?
Well, it is an interesting area and certainly one of key interest for me. I think that there's really a large evidence base now suggesting that lipoprotein little a is part of the causal pathway for atherogenesis. And it really, I think people need to think about it as independent of LDL cholesterol. You might have what appears to be a relatively well controlled LDL cholesterol and yet have a very elevated LP little a. And unless you're testing it, you're not going to know that patient's at high risk. So this is outside of the ACS guidelines where we didn't get into LP little a. But many different consensus groups now recommend that everyone have their LP little a checked at least once in their lifetime. Should you check it in the throes of an acute ACS? It may or may not be the right time, only because those values can change to some extent in the setting of an ACS. Um, but but that being said, I'd rather that it be checked than never at all. And there are many different LP little a lowering therapies that are currently being evaluated in phase 2 and phase 3 testing. And so we may have in the not too distant future effective therapies for lowering it that hopefully will be shown to reduce risk of cardiovascular events. So I think, absolutely, you should check somebody's LP little a. And, ideally not at the time of the ACS, but if that's when it needs to be drawn, I think that would be fine too.
All right, excellent. I think for the vast majority, we've covered how to manage patients with acute coronary syndrome, right from diagnosis to early intervention versus selective invasive strategy, to then post-PCI medical therapy. Is there anything you think we have not covered? I know we did not specifically talk about multi-vessel revascularization in the setting of, for example, STEMI with non-culprit lesions. But is there anything else you think we have not touched upon?
Always so tricky, right, to tackle it all in the span of time that you want. But like you said, I think one of the key messages as well is completely vascularization in ACS patients both in STEMI as well as non-STEMI, in the absence of them being in acute cardiogenic shock. So we have, new data supporting that with a corresponding recommendation. Options for, other things like virtual cardiac rehab, which I think a lot of people are not aware of, as opposed to in-person cardiac rehab. Of course, in-person is always preferred, but for some patients, they may not be willing or able to attend in person, and so a virtual is something that should be considered for those folks as well. There's so many exciting areas of ongoing research. We didn't touch upon the use of mechanical circulatory support devices in cardiogenic shock. That's a whole separate, you'll have to invite me back for another podcast. And other areas of interest too, like GLP-1s. Should we be starting those in the hospital for a patient, perhaps who has obesity, for instance? So lots of exciting areas that are still being explored, and I think we'll be bringing further guideline updates along as new evidence continues to accrue.
Yes, I try to do our best to cover an exhaustive document, within the spectrum of an hour. Yes, and I agree with you. I think we'll have to get you back on specifically talking about cardiogenic shock, and ACS with shock is a whole. It requires a whole different discussion here. But no, thanks again. I think this has been very enlightening. I'm sure will be useful to the listenership. Anytime a guideline update as important as managing acute coronary syndrome comes out, which is bread and butter cardiology for all of us, whether we are general or interventional cardiologists or preventive cardiologists, I think all of us manage patients with acute coronary syndrome or see them as follow-up in clinics. I think this is an important topic for discussion. So thank you for sharing your insights. I think it's great to hear from someone who authored the guideline for the college and for the American Heart Association. Any closing remarks for Parallax?
No, just that as I mentioned, that I think that there are so many areas where we're continuing to learn so much about the optimal management of patients with ACS. So I think that we will see things continuing to take shape over the next few years, and thankfully we're not going to be waiting a full other decade to make updated recommendations as needed. So we'll be watching closely, and stay tuned as further updates will be expected to occur on a fairly regular basis moving forward.
Absolutely. Well, thank you. And thanks again to everyone for listening. Do share your feedback with us. We take it seriously. You can email us or share your feedback with us on social media, LinkedIn, X, or Instagram. If you have any questions for Dr. O'Donoghue, please email them to us, or you can email it to her directly. We'll make sure that we include her email address in our show notes. And until other Monday, thank you for listening.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.